Hello, everyone. Thank you for sticking with us. We are excited to start our final panel of the day to talk about telehealth and cancer care. As we all know, the COVID pandemic led to dramatic increases in the use of telehealth for many types of healthcare, including cancer care. I'm pleased to have a wonderful panel to discuss different aspects of telehealth and cancer care. At last month's ASCO Quality Symposium, there were several presentations on telehealth, and we wanted to highlight some of those findings by bringing them here to you. So Dr. Cardinal Smith from the Icahn School of Medicine at Mount Sinai presented on disparities in the use of telehealth, and she's going to share what she's learned so far with us. Dr. Jennifer Temmel presented on a study that she's doing on telehealth for the delivery of palliative care, and her colleague, Dr. Laura Petrillo, is here with us today. Additionally, we wanted to share findings of the focus groups that NCCS conducted in May and June to ensure that the patient perspective in telehealth is considered. We worked with a wonderful consultant, Kristen McNiff-Landrum, on the project, and she's going to share about what we found. And finally, we have Dr. Jennifer Malin from United Healthcare to talk about how payers are thinking about healthcare as it relates to both reimbursement and quality of cancer care. So we're going to start with Dr. Smith.
Thank you so much for having me here today. I'm excited to share with you all what we presented at ASCO Quality. Or an abbreviated version of that, I should say. So, you know, as you all know, I am in, well, maybe you know where Mount Sinai is. I'm in New York City, New York, which was the epicenter of the pandemic early on when it first started back in March 13th. Many of us will never forget that date. And at that time, you know, we really didn't have telehealth stood up within our institution, let alone within cancer. So this graph shows you by visit type, so either a video visit or telephone non-face-to-face and telephone face-to-face encounter, non-video encounter, between January and August 2020. And really in January and February, we had essentially no one using telehealth at all. And then in March, we started to ramp up where we essentially peaked in April to May with, you know, a little over 3,000 total video visits across our health system. And to give you some context, our health system is comprised of 5 ambulatory cancer sites where we see 12,000 new analytic cancer patients per year across the system. The purple here is the video visit and the blue is the face-to-face or the telephone calls. And since the pandemic started to slow down over June and July and August, you can see that we have come down, and I don't have the updated numbers here, but we've sort of plateaued in the 500s as of right now. And one of the things that we, you know, anecdotally we recognized were that our minority patients were utilizing the telehealth visits much less than our non-minority patients. And so for the purposes of this, we consider minority patients as those who are Black or Latinx, Hispanic or Latinx. And so of the total, almost 7,700 total telehealth visits that we did between March and June of this year, we looked to see what the breakdown was by race and ethnicity of our total patients that we normally see compared to those that utilized telehealth as a whole, video visit, or phone visits. And so the mean age of patients were 65. About 76% of all of the telehealth visits were video visits. However, we saw significantly less utilization by Black and Latinx patients for telehealth total, and this included they were less likely to use videos and more likely to utilize telephone encounters. And so what this graph shows you is on the column all the way to the left are percentages of our total patients. So for example, in our Black patients, while they represent about 23% of our total patient population seen during this period of time, 19% of them used telehealth. 19% of all of those patients who used telehealth were Black, and 17% used video visits compared to 23% phone visit. And you can see that the use among Hispanics or Latinx population was even less. And so, for us, I think this is one of those things where, technology often moves before the way we're able to really put care structures and care delivery models around it. And one of the things I found, even to think of anecdotally, is even if a patient of mine was signed up to use our patient portal, they didn't actually have access to it. It was their child in California, for example, who had the access and the log on to it, and they didn't. And so I think when I think about lessons learned for us is that it's so much more than just, is this person signed up to the patient portal? But is this patient signed up to the patient portal? Does this patient know how to use it? Do they have access to it? Do they know the features that are involved in it? And how can we help them? And so from this work, one of the things that we've been able to do is through the CARES Act, the FCC had $200 million that they were giving out in grant money to improve, remote monitoring telehealth. And so we applied and we received money to really look at improving our remote monitoring device capabilities. And we're partnering now with a company. Actually, our first devices just went live this week, where we're giving them to patients who, either are in the home and sick and worried about their exposure because of COVID, or they're starting on new cancer treatments and therapies that we know have a high likelihood of requiring healthcare utilization, ED visits, admissions, et cetera. And so we're giving them these devices that measure, blood pressure, temperature, pulse, oxygen saturation. And it also comes with two things that I think are important. One is that it comes with a hub. And so the hub will boost whatever Wi-Fi broadband you have in your home, or it gives you the data that you need to be able to utilize the devices. And then second, it provides each person with this device with a tablet. So they have a tablet in the home and you're able to do video visits with that person via that tablet. Or, you could push out patient reported outcomes or other sort of survey measures or questionnaires that you think might be important clinically. And so, we are excited to roll that out. I think that, it's one of the ways that we're hoping at least we can decrease the barriers that exist in this access to care, really sort of bridge that digital divide, so to speak.
Great. Thank you very much. All right, so now I'm going to turn it over to Dr. Petrillo.
And all right. Well, thank you so much for having me. So I'll be speaking about the using telehealth to expand the reach of palliative care. The reach of palliative care. So I have no financial relationships to disclose, and I'll be speaking, I want to acknowledge the funding of the Patient-Centered Outcomes Research Institute for the Reach Palliative Care study that I'll be discussing. So I want to first start with a brief story. In my role as a palliative care physician, I recently saw a young woman in clinic who had early stage cancer, had recently completed what we hoped would be definitive therapy with chemo and radiation, and was coming in for a visit for a scan review. It was actually a joint visit with her medical oncologist and her radiation oncologist. And the medical oncologist and radiation oncologist and I first met for a few minutes for a pre-meeting to discuss what we saw on the scan and make a plan for our discussion with the patient. Then we let the patient in from the waiting room with her husband, her sister, her 6-month-old baby. And we had a conversation about kind of what we asked about all their questions. We talked about next steps. We made sure that they had clear understanding about the plan and tried to just make sure that the patient's goals were heard and could be honored in her care going forward. And I had worked with this patient before for symptom management, but this kind of particular family meeting goals of care type visit is kind of one of my favorite aspects of palliative care, kind of to do that care coordination and help with communication. And that meeting it was a good conversation. We came to, we had a good exchange. I felt like all of the patient and families' questions were elicited and answered. But there was something really different about that meeting than the similar meetings that I'd had just a few months prior. It was during the COVID-19 pandemic. And so that video visit was via telehealth. And so it occurred to me as I was leaving the meeting that not only was the meeting as good as it might have been in person, but in some ways it was actually better, which is not something I would have expected kind of prior to the necessity of everything moving into this space. The patient was at home on her couch with her baby on her lap. Her sister joined from out of state. The radiation oncologist, medical oncologist, and I, 3 specialists, were able to coordinate our schedules to be in the same place within a few days of this patient's scan, to be able to have this kind of multidisciplinary hour-long discussion. And I was joining from home on a research day and was able to hang up the phone after that emotional conversation and go downstairs and hold my own baby for a few minutes before going back to work. And so for all of us, there were kind of reduced burdens. The patient and our family didn't have to come in and drive nearly 2 hours each way to the cancer center with the expense and kind of physical burden of that, or take a day off work for the caregivers. So it just highlighted kind of some of the many advantages that we've been seeing with telehealth. So I want to briefly just review the evidence for integration of palliative care that I'm sure this audience is very familiar with, give an overview of this clinical trial of palliative care delivered via telehealth, and then talk a little bit of some of the early lessons learned from the trial. So again, as I'm sure this audience is familiar, the integration of specialist palliative care with oncology care improves quality of life for patients with advanced cancer. And the study that sort of put this on the map was the study published in the New England Journal just 10 years ago by Dr. Temmel and her team, looking at the integration of palliative care for patients with advanced lung cancer that found improvements in quality of life and symptom burden. Another kind of early piece of evidence that demonstrated the value of the integration of palliative care was actually the ENABLE trial, which used telephone-based nursing-led delivery of palliative care for patients with advanced cancer. Also saw improvements in quality of life and mood, and a trend towards improvement of symptoms. And that really led to the kind of recommendations that palliative care should be integrated with oncology care from the time of diagnosis for all patients with advanced cancer. But one kind of question now, as we are moving into this time and space where it's clear that there are advantages to integrating palliative care, but there are many challenges to delivering it on a wide scale. And so Dr. Temmel and Greer have undertook this REACH-PC multi-site large randomized clinical trial to compare whether palliative care delivered via telehealth is equivalent to palliative care delivered in person. These are just the sites that are involved with this large study. There's 17 states and 20 sites. And the study actually opened prior to the pandemic, so it opened in 2018, and 581 patients and 315 caregivers had enrolled. Of note, the reasons that people didn't enroll among the patients who were approached who declined, only 7.6% kind of cited discomfort with technology as the reason. These are the demographics of the patients that are currently, these are the demographics of the patients that are currently enrolled. So it is an older population, 82% white. And I wanted to highlight that most patients, about half, are greater than an hour away from the cancer center. And they frequently use technology, so on a daily basis using the computer or smartphone. In terms of the challenges that clinicians report, these are just surveys that clinicians fill out after, and so there are close to 3,000 visits that have already been conducted via either video or in person. And some of the things that we might anticipate as being challenges, clinicians really have not been finding, such as difficulty addressing topics that felt uncomfortable over video, or difficulty establishing rapport. Of note, 19% of the video visits did have some technical difficulties with visits, and I'll just say anecdotally, as one of the interventionists in this study, we often will end up converting to telephone if the video is not working. And also, The first platform that we tried out was a little glitchier than what we have now. There was like rapid improvement in technology with necessity with the pandemic. So this is just showing that there wasn't a difference in how clinicians perceived their ability to accomplish their goals in the visit as a function of these challenges that they faced. There was no difference between the video and the in-person visit. I'm sorry, I don't know why my slides are like on lightning speed. Finally, these are some of the issues that we anticipated on the left of that would be special issues for palliative care. So lack of ability to use touch to establish rapport and support, difficulty controlling the environment, challenges with prescribing opioid analgesics, and these intimate communications. And on the right are a couple of quotes from clinicians in the study. So certainly some people did feel they wanted to reach out or hand a tissue or help if somebody was sick. People did note challenges with communication. But in general, some of these other challenges, actually, the prescribing opioid analgesics challenge has been helped certainly by accommodations that have been made during pandemic time. Finally, here are some of the challenges with delivering in-person palliative care that we've actually seen that telehealth can help overcome. So coming to the hospital, as we know, there's a huge financial burden for patients for transportation, parking, taking days off work. There's also those challenges for caregivers in the second column. There's the increased kind of time in the medical center just spent waiting between appointments and infection risk. And the other thing that my patient encounter highlighted is that sometimes there's this long lag between scans and review, and that can actually be cut down significantly with telehealth. It helps too for clinician side with coordination of visits. And then another thing that I've definitely noticed is that there's so much care coordination that happens outside of billable time that we can now kind of plug into video visits instead and address patient concerns with visits on the fly more often. And for health systems, the limits in space, like clinic space for having visits, as well as the high no-show rates have been really affected in a positive way by telehealth, being able to reach more patients. So in summary, telehealth is a valuable tool for delivering supportive oncology care, especially for those most vulnerable. And using telehealth does pose unique challenges, but so far, at least in this clinical trial, we have not seen significant barriers to achieving care goals. This is with the heavy caveat that we acknowledge that there are patients who are not being reached by telehealth, and that they are that is an important area in need of attention to equity. Thank you.
Thank you very much, Dr. Petrillo. Now I'll turn it over to Chris.
Thank you. I'm so happy to be here to talk about the NCCS project that Shelley mentioned in her introduction, where we had the opportunity to hear directly from patients right at the beginning of the public health emergency about their experiences with telehealth and their perceptions of the future of telehealth for cancer care. So we did want to hear directly to receive direction from cancer patients and survivors about how to maximize the benefits of telemedicine, and also to get reaction from cancer providers about the main themes that emerged from the discussions with patients. Ultimately, the product, which I'll be able to share the URL for this, and I think Shelley will provide it as well, are now available on the NCCS website to provide resources with recommendations for patients, for cancer providers, and for policymakers. So the main methodology here was focus groups that we conducted in June and July. We had actually a series of focus groups with diverse patient participants who were identified by our project steering committee. And then, as mentioned, we compiled the main themes using qualitative research methods, and we're able to get feedback from cancer providers on those resulting themes. So what we learned from patients at a very high level is that telehealth has been able to fill a critical gap during the COVID-19 pandemic, especially very early on in the pandemic. But as you can see from the quote here, we heard that these telehealth visits really weren't considered a substitute for face-to-face. Although, as Dr. Petrillo mentioned, we did learn that there is definitely potential for excellent care provided using telehealth and telemedicine services, but really additional planning is required to ensure that telehealth is maximally beneficial. And definitely we heard a lot about some of the themes that Dr. Smith mentioned about ensuring that we're avoiding unintentional consequences as we add telehealth, especially as a alternative or a replacement for traditional face-to-face visits. I'm going to quickly go through some of our top level insights and provider recommendations. And again, I'll show you where you can access this in more detail on the NCCS website. So first, we heard from our participants that there's more thoughtful planning required on the part of oncology clinicians to really consider the types of visits and the types of clinical scenarios that are appropriate for telehealth instead of in-person visits, and that in-person visits are really still needed for that relationship building and that direct reassurance that is so important during cancer care discussions and communications. We heard that specific strategies and communication tools to ensure that those telehealth visits are successful. And I think that really a lot of progress has been made between even the time when we had these focus groups and today, but still that this is an area where ongoing investment on the provider side is really needed. And really that oncologists and their team need more telehealth training themselves, and they need better workflows to prepare patients to be successful participants in telehealth visits. We also heard that patients need better insight into the cost of these telehealth visits. And this is an area that we've seen evolving and changing during the course of the COVID public health emergency. And I think we've got some insight into what might happen in the future, but this is certainly the out-of-pocket impact on patients is critically important as we think about telehealth moving forward. We also had an ongoing theme that telehealth should be offered and covered to replace some cancer care, but that should really be based on patient preference. So again, really thinking about what's appropriate and ensuring that replacement of those in-person visits with telehealth is something that is consistent with the patient's own preferences for visits. And then we had really interesting discussion about how telehealth could be a mechanism to actually remove some barriers that are in place right now in the healthcare system for cancer care and to catalyze innovation. And we'll talk more about that in just a moment. On the provider side, the main recommendations that emerged were to again, really ensure that there's agreement from individual patients. This really is an individual choice. There's not consistency. And certainly we heard great diversity in our focus groups about comfort with different types of visits, different types of communication delivered via telehealth. So really it is an individual patient choice issue, and that providers need to be very cognizant of that and to be having that individual discussion with patients about the appropriateness of telehealth versus in person. Again, those workflows to ensure that patients feel confident and comfortable and have the information that they need in advance of a telehealth visit, and then appropriate follow-up after. And we heard a lot about kind of supporting technology that could be useful to ensure that this happens most effectively, whether that be through patient portals, follow-up emails, et cetera. We talked about costs of telehealth, and we certainly, again, encourage providers to be very aware of the out-of-pocket costs to patients. And then certainly understand, and I think there is, again, a growing understanding across the provider community as well, that there is some difference and nuance, and I think we heard about it a little bit already today, in the types of communication skills that are required doing a telehealth visit instead of a face-to-face visit. So how can we help providers to really be maximally effective in that communication, and understanding how it might be different in person versus via telehealth. So just to quickly summarize, and then I'll show you where you can find more information since I was very brief here. The main takeaways are that telehealth, again, should be offered and covered in the future. That really, kind of pulling back the opportunity for patients to be able to benefit from the enhanced efficiency and in some instances, effectiveness of telehealth shouldn't be something that we have to address after the COVID pandemic. We really want to continue to have the ability to offer telehealth into the future. It should be based on patient preference. There was a great consensus that telehealth, that patients will benefit from telehealth not only with their oncologist or their providers, but also with other team members. And I know that presents some challenges, but that there really is critical importance to being able to access those care team members regardless of the type of visit. And that careful consideration of that timing and availability of services, as you heard from previous speakers, is very important, that the tests and scans and the ability to access the information that's needed for an effective visit is planned into the sequencing and timing with telehealth, just as it would be for an in-person visit. And then that telehealth can be a mechanism to remove barriers and catalyze innovation. And on the flip side is, again, as you heard already, especially from Dr. Smith, if this isn't done, it could exacerbate disparities. So we did hear about the critical need for, the technology, the Wi-Fi, appropriate bandwidth, and that if the healthcare system is going to invest in telehealth, part of that investment needs to be making sure that patients have what they need when they are expected to participate in those discussions. But also beyond that there's this opportunity to promote multidisciplinary care planning, care coordination, second opinions, maybe clinical trials, certainly receipt of supportive care services. We also talked about palliative care specifically, and support groups using telehealth, and that we should continue to evolve these as we move forward. So this is the website on NCCS's, or the page on NCCS's website that provides access to the reports resulting from this project and more background information. And we would love for you all to check that out and give us any feedback that you have. I do just want to very, very briefly give special thanks and recognition to our steering committee members who were instrumental in planning the project and in helping us recruit really amazing focus group participants, the project team members, and Pfizer for supporting the project.
Great, thank you so much, Chris. You gave a great overview of what we learned, and we loved working with you on this project. And I also want to thank our steering committee, the advocates who really that helped us to kick this off, find the right patients to participate, and then review all the products. So now I'm going to turn it over to Dr. Malin to give us a payer perspective.
Well, good. I guess it's afternoon for most folks. Good afternoon, everyone, and thank you for including me on this panel. And it's been wonderful to hear some of the stories and the research that's already happening in this space. I was reflecting as folks were talking, especially Dr. Petrelli. So I remember in medical school and residency, we were actually taught not to deliver any important news over the phone. And we were told that especially if you had results of a biopsy, you needed to schedule a follow-up visit, regardless of what the result was going to be, because you didn't want to telegraph whether it was going to be good or bad news. And so, we routinely felt that any important information had to be communicated in person. So I think it's not surprising given how ubiquitous technology and screens and phones have become in our lives today that there's been such a shift. but I think it is interesting to reflect on where we've come. And before I maybe jump into some of the more kind of policy and payer perspective, I also just wanted to share my perspective too as a clinician. I still volunteer at the VA, and we often hear that older individuals can't, aren't going to be good subjects for telehealth, that they're going to need the in-person. And I had the privilege of caring for a 98-year-old veteran as he was, facing the terminal phase of his illness with hepatocellular cancer, and he lived 2 hours away from the VA up in Santa Barbara, and his kind of terminal phase happened right at the beginning of the COVID pandemic. So we did the last few visits by phone, and it was his preference so that he wouldn't have to drive. And unfortunately, our clinic wasn't set up for video visits, so it had to be by phone. But much as was described, we were able to conference in his daughters that way, which we probably could have done in an in-person visit in that situation. But I think there is something where you do feel like maybe the phone would be impersonal, but in some ways, because you might be connecting in a way where that person is in their home, that there is definitely a personal quality to it as well. So I guess from that context, I just wanted to highlight on, really kind of within the framework of access, quality, and cost, and just some themes, kind of picking up on some of the themes we've heard today, and, how we think about that going forward. So I would say, at this point, telehealth during the COVID-19 pandemic, really the focus from payers and providers, and I think all of us, has really been about how do we use this technology to ensure access. And so, providers, I think, have been, trying to ramp up as quickly as possible to provide this service. And payers, I think, for the most part, have been covering telehealth and reimbursing it in the same way that they would in-person visits in order to be able to ensure that access. And I think certainly throughout the public health emergency, we'll continue to see that. I think, though, as we start to think of, hopefully a post-COVID world, telehealth is going to be a robust part of that. But how do we, at that point, start to, pivot from not just thinking about access, but to also considering what role does telehealth have in providing quality care, and continuing to ensure that care is cost effective, or that we can provide care that's affordable, and the most appropriate care for the patient at the right place of service, essentially, with telehealth or home, or the location of the patient's preference being part of that continuum from inpatient, outpatient, hospital, clinician, home, kind of all those different venues. And so I think it's going to be really important for the research, and it's, I think, what a gift that there's this trial already ongoing about delivering palliative care through telehealth, that we'll learn from that. But I think we need a very robust agenda. And, I think it's going to be really important to understand for all of us in general as patients, regardless, and especially for cancer patients, which visits are good for telehealth and which ones are not. Certainly, the anecdote of, our strong belief that you shouldn't give biopsy results over the phone from, 30 years ago is probably not necessarily the case today. But I think we do need evidence-based information, or data about clinically what types of visits should be done, are appropriate for telehealth, and what things need to be in person. And how do we anticipate that before the visit? Because, once you're in the midst of the visit, to realize that you need to do a physical exam isn't, it's still useful. You can then have that patient come in for a physical exam, but it's not necessarily, leading to a quality encounter at that point in time. And, so thinking about quality then in terms of both the clinical quality of the encounters, but then also how that impacts patient convenience or the patient experience of care. In the ideal world, right, and where telehealth has been thought of as being patient-centered, is for low acuity conditions where you can take care of the condition, in that one visit. And so that clearly is likely more convenient for the individual. But if it requires you to schedule a telehealth visit and then still come into the provider's office, and so now you've turned one visit into two visits, it probably isn't so convenient, unless the second visit is now somehow more targeted. So I think, thinking about it from the convenience standpoint, and then the cost standpoint as well. So obviously turning one visit into two visits is probably not necessarily lower cost again. But I think the other piece to reimbursement is that there's, as reimbursement rates are set for visits, through the whole RVU process and the RUC and, the different types of services, that tends to encompass a lot of services that we don't necessarily think about. It's not just incorporating the face-to-face time that the clinician might be spending with the patient. And so to the extent that telehealth ends up splitting up those aspects of care into several different aspects, where maybe you need a home health nurse to go out to the home to collect some blood, or, there's different ways that single encounter gets split into multiple encounters. I think we'll also have to think about how do we, reimburse all the different parts. And then, I think back to one of Kristen's earlier points is, both thinking about it from a payer perspective and the healthcare system overall in terms of reimbursement and cost, but how does that impact individuals' costs of care? So, if a telehealth visit ends up converting what would have been a single encounter with one copay into three smaller, more targeted encounters, do patients have multiple copays for that? Or is there a way to kind of bundle it together? I think in summary, I think this is an exciting time. I think from United Healthcare's perspective, we see this as an opportunity to support innovation and new ways of delivering care. Our sister organization, Optum Care, which is one of the largest primary care practices in the country now, is also very actively looking at ways to support telehealth and bringing that to patients. And we hope that there's synergies for us as an organization to rapidly test new models and figure out what works for patients. But I think, it's going to be really critical that we have a robust research agenda to make sure that we understand how to ensure that, the triple or quadruple aim is met through this expansion of services. And again, that we don't see increase in disparities because of lack of access to the technology and platforms. And I think that's probably enough from an opening, and I look forward to the panel discussion and questions.
Great, thank you. I have a lot of questions myself, and we've gotten a few from the audience. You should feel free to use the Q&A tab. But I wanted to, you talked a little bit about what is an appropriate type of visit for a telehealth visit, and about your, the training in medical school of not delivering bad news. And Chris can talk a little bit about, we did get kind of a range of different more and to less acceptable types of visits from the patient perspective. But I think also, when you're thinking about delivering bad news, there's probably a difference between, a phone call from your oncologist where there's not really that time to actually have a planning discussion about what the next steps are. And then this multidisciplinary type of appointment that Dr. Petrillo talked about, where the whole team is on to have that discussion about, goals of care and kind of what's the next step. So and maybe Chris, I don't know if you want to talk a little bit more about kind of what we heard and the more to less acceptable types of visits from the patient perspective.
Sure, I'd be happy to. So those, and probably folks won't be surprised by the most and least acceptable, but I think what was most interesting were where we really got mixed feedback. So most acceptable were routine follow-up visits, standard monitoring. So for those, especially on oral therapy, the standard monitoring, side effect monitoring between in-person visits, and that may be, where that potential additional visit. But I don't think it wasn't only discussed as in between routinely scheduled visits, but maybe lengthening the time between in-person visits and filling some of that space with telehealth visits for monitoring of side effects. For post-surgical follow-up, for second or third opinions, including across state lines. And I think we actually got that question about that. Clinical trial monitoring, for some kind of just, our folks referred to it as check-in visits for those patients who were considered high risk for one reason or another. And, I'm not sure that right now we have a perfect future strategy for those kind of check-in visits, but that was one that really came up. And we had a lot of discussion around mental health visits. And that's where actually most of our focus groups members they had more personal experience with visits with their mental health providers than they did actually with their oncology providers, although a lot on the oncology side as well. And then what felt least acceptable, the first was a first visit or meeting with a new provider. So maybe you had met your radiation oncologist briefly 3 months ago before you started chemo, and now it's time to start rad-onc, and you're meeting your new provider for a planning visit for really what feels like the first time via telehealth. So people were pretty uncomfortable with that first visit happening via telehealth if there was not already a relationship established. Those who were symptomatic, and that may, we really focused on that for those who were in their survivorship phase and were concerned that the cancer was recurring. But we also heard that for those who may have been receiving treatment and were concerned that their cancer was worsening. And treatment planning visits, there wasn't a lot of support for doing treatment planning visits in general via telehealth. In the mixed areas where I think it's most interesting. So we had very diverse opinions about delivering bad news. So back to Jen's comment, that some of our focus groups, and there was a lot of internal discussion and debate, healthy, kind debate among our focus group participants about this. A lot of folks said, if you're going to receive bad news, being at home with your support, having your family and friends or whoever your support network is there with you is actually better than having it being in the provider setting and not being able to have that immediate access to your support or your comfortable surroundings. Others had absolutely no interest in receiving having the potential to receive bad news at home. They wanted that to happen when they were face-to-face with their provider and they could get that direct information and support from their provider. We also had really mixed feelings about some of those visits where patients would need to provide clinical information to their providers. And we heard a little bit about this from Dr. Smith about how they're supporting patients in doing this, but there was a lot of discomfort. And again, this was pretty early in the June feels like a lifetime ago, but there were a lot of our focus group participants felt very uncomfortable about having to do anything other than take their temperature. They feel very uncomfortable about having to do their blood pressure, about having to do any sort of other kind of clinical information gathering in advance of the visit. So it's a place where I think there would need to be, at least according to our focus group respondents, there would need to be additional kind of work and investment to help patients to feel more have more self-efficacy in that space. We did not hear that at all from our focus groups. I think those were the main things. Did I miss anything, Shelley?
Yeah, no, that's right. I think, the fact that the patients that in our focus groups were so split on whether they want to receive bad news, maybe means that we needed to be asking patients ahead of time, how do you want to receive news? I wonder if, Dr. Petrillo, in your study, are you all doing anything to help with any of that sort of clinical information that needs to be collected and how you manage that with telehealth?
It's a great question. I mean, we are actually still kind of by necessity doing so much of our visits via telehealth, at least for palliative care. So for oncology care, when patients have to come in for their chemotherapy, of course, they're coming into the hospital, but then they're getting their sort of monitoring visits via telehealth. And so for palliative care, I'm doing a lot of my monitoring of symptoms via telehealth. But I have found that two things. One, coordinating with visiting nurses, particularly for patients who are kind of post-acute hospitalizations or who I'm just concerned about, will request sort of to get visiting nurse assistance. And that's another set of eyes and ears in the home. And then the other setting that I've found is towards the end of life, kind of just thinking about I wouldn't say that during the pandemic, patients were transitioning to hospice sooner, but it was always a relief when a hospice team could come in to have kind of eyes and ears on a patient you were worried about when we absolutely didn't have the option to bring people in. So I think those are two kind of home services that that I know that I've relied on during this time.
Mm-hmm. That makes sense. So a question from the audience is, which Jen mentioned, but if anyone could speak to issues around state licensure, because one of the things we did hear from patients in our focus group is that they want the ability to use telehealth for second opinions. And, there's ideally this could sort of help allow people to get second opinions from a cancer center that may be outside of their state without having to travel. But this question says that they're hearing from patients who are unable to get remote second opinions via telehealth due to lack of licensure in specific states.
Yeah, so I think the state by state licensure requirements have been one of the things that's really restricted telehealth in general, and I think some of the relief during the pandemic has been one of the things that's really helped things to blossom, and I think does make the potential for having remote second opinions really viable. I mean, I think the various second opinions today for oncology, which I think are really important for many situations, have either required patients to travel, or there are some companies out there that provide a quote second opinion, but it's really they try to get around the regulations by having it be more a sort of quote education that's tailored towards the patient, and at least in my perspective isn't really a true second opinion. So I would say that I think this is an area that NCCS and the advocacy community can really help drive change that's lasting. I think there's various state medical boards and other provider boards have maybe been somewhat entrenched, and I think maybe having more national licensure requirements is probably more in keeping with the way we all expect to receive services in general, not just for medical care.
Yeah. And I mean, I completely agree. And if I could add to that, I would say that, just thinking about as a clinician myself and what it has been like during this pandemic, you can't keep up, right? Like the rules keep changing. Every day the system's sending out a new email about the date changing for when you need to, for when you can no longer see a patient, via telehealth based on the state they're in. Or instead of the emergency sort of relaxation, now you have to at least fill out a form and register with the state as opposed to being completely licensed by the state. And I think really moving towards something that is universal, because, when we talk about those barriers for those that live in rural populations or minority communities not having access to, specifically thinking about, NCI designated cancer centers or having access to clinical trials wherever they may be, this is a potential way to overcome some of those barriers.
Yeah, and also some of our colleagues in the patient advocacy community really try to educate their patients to seek, centers of excellence for in the type of cancer that they have, particularly if they have a rare disease or a rare subtype. And I think this would help to be able to, have that access to those specialists.
Yeah, I agree completely. And, we always think about the access to specialists and clinical trials as being, that one of the barriers is the cost barrier related to insurance coverage or potentially being out of network. But I think it's been shown, certainly for clinical trial participation, and I would imagine that the same thing would carry over for second opinions, that the travel costs are substantial, and that in and of itself is a barrier. And if you can, if someone's sick and they need a family member to take off time from work to travel with them, all those things are barriers. So it seems to me this is, really one of the ways that we can really improve quality of care through telehealth access. I mean, I think it still gets down to those barriers. And I thought some of the comments Kristen made from the focus groups are interesting. And my sense is, that the issue is, yes, we would all probably prefer an in-person visit if it's available, right? Especially if there's going to be bad news. On the other hand, if it means driving 3 hours and sitting in traffic and driving 3 hours, right? So there's trade-offs that I think all of us, would make in those circumstances, and our patients do as well. And the issue is just honoring preferences, right? Because everyone's perspective on what's a long drive or an expensive plane flight is going to be different.
Well, and potentially this could, if the only patients who have the ability to travel to another state to receive that kind of care are people with means. And so if we can democratize it a little bit by allowing people who don't have, the ability to travel, then I think that can help toward reducing disparities. I know, so I wanted to ask Dr. Smith about education and support for patients in terms of collecting that clinical information to prepare for the telehealth visits, like taking blood pressure and providing PROs. Is that something that you're going to be doing as part of this grant?
Yeah, I mean, reimbursement does exist for the monitoring. So specifically, if you collect 16 data points within a month on one patient, then you can bill. And so, while we have this 1 year of these devices essentially for free, we are going to use them, implement them, track healthcare utilization, patient satisfaction, experience, outcomes, and measures, and then really seeing if it's something that can be sustainable, that we can continue once that runs out.
And I know, as far as getting devices in the hands of patients, I know that I've talked to some cancer centers where they've actually provided the tablet to the patient so that they have the ability to, to use it for telehealth visits. And I know that that's not, that funding has to come from somewhere. I wonder, Jen, from a payer perspective, is there any hope that payers would help provide that to patients who don't have it? Or is that, because I think not everybody's going to be able to have the kind of grant funding that Dr. Smith was able to get?
I think payers essentially have to kind of figure out how to deliver the care for folks, within their charge in the most affordable way possible. So, there's certainly within our Medicare plans, we do all sorts of things to facilitate home-based care. And part of that is because the payment for a Medicare member increases if they have, if you can identify that they have comorbid illnesses. So I think kind of within the overall structure, I think there's ways to incentivize payers to be able to provide those services, and we just have to think through what those different levers are. But I think certainly, and I think the other thing we should think about, hopefully, I guess, with the as the pandemic becomes a distant memory, maybe the educational barriers won't be as much of an issue. But I think, the same kinds of disparities that we're seeing right now in terms of access to telehealth, exist for children trying to do remote learning. And there may, even though hopefully most children will be able to be in classrooms in the future, there may still be some aspects of remote learning that are, just like telehealth, that are become kind of universally valued ways of education. And so maybe there's ways that we need to kind of partner to get the services in people's hands.
Yeah. I thought a lot about what are the things after we get through all this that we're going to keep, and what are the things that we're going to be looking forward to going back to. I know that for me, one of the things I'm going to be looking forward to going back to is having these meetings in person, because it's really great to be able to see everyone. Although it is nice, I think, sometimes we can get busy clinicians and payers who maybe wouldn't be able to fly across the country to be with us, to join us remotely. So I want to thank all of you. I know we could keep going on in this conversation, but it's 3:00 and I want to let everyone go. But thank you so much for joining us and for sharing your perspectives and your research. And I want to thank everybody for joining us today. And please know that we will be sending you an email with links to the recordings of the presentations, and also a survey that you should be getting soon. I'm sorry, it'll go out on Monday. And we will be scheduling our dates for next year's symposium, next year's roundtable, and hopefully we will, at least by fall, we'll be able to be in person, and we're hopeful that we can all start getting back to normal at some point in the future. Thank you again, everyone, and I hope you have a great day and stay well.